everyone. This is the prostate cancer part 2. We'll speak about the management of the BIN, a low-grade BIN or focal high-grade BIN, monitor digital rectal examination and PSA. So it's monitored by digital rectal examination and the PSA. This is the low-grade and focal high-grade BIN. Biopsy, again, if indicated based on the PSA or digital rectal examination. A multifocal high-grade BIN, that's 3 sites, includes 3 sites. So monitor includes PSA and digital rectal examination, rebiopsy of the prostate in 1 to 3 years with increased sampling from the high-grade BIN regions and also from the adjustment region. When extensive high-grade BIN is present, confirm the absence of ductal cancer and also intraductal cancers. So for this patient with high-grade BIN, we consider rebiopsy in 1 year. Here, this is multifocal high-grade BIN. The rebiopsy will be done in 1 to 3 years with increased sampling from high-grade BIN regions or from adjustment region. This is a rebiopsy must be from here. We'll speak about the atypical tissue. The term atypia, atypical gland, and atypical hyperplasia are none or not specific and should be avoided. We have atypical adenomatous hyperplasia. This is known as adenosis. Also, weak circumstantial data link this entity to prostate cancer. Follow-up of limited number of cases suggests benign outcome. This is for those group of adenosis. So the guideline mentioned that the follow-up of a limited number of cases suggests it is benign. Therefore, isolated atypical adenomatous hyperplasia or isolated adenosis is generally considered benign. So rebiopsy is usually unnecessary, but the clinical follow-up is warranted. So just in case of adenosis, we prefer to do clinical follow-up. Atypically small acinar proliferation, or known as ASAP. This is also called atypia suspicious. Okay, so it is known as atypia suspicious. This is atypia suspicious for carcinoma or atypical gland suspicious for carcinoma. So this is atypical small acinar proliferation or known as ASAP. ASAB. ASAB is gland or gland suspicious for cancer, but there is insufficient and or cytological atypia for diagnosis of the cancer. So we have insufficiency and cytological atypia to diagnose the patient with cancer. Okay, so it is known as a atypically small acinar proliferation. Okay, so it's atypia suspicious for cancer or atypical gland suspicious for cancer. Atypical small atypia proliferation has a well-documented association with prostate cancer. So have a well-documented relation with prostate cancer. 40 to 60% of the patients with ASAP have prostate cancer. So it's very high percent. 60% of the patients with ASAP have prostate cancer, but 40% is benign on subsequent biopsy. So on subsequent biopsy, 40 to 60% have prostate cancer. The cancer is usually found in same regions where the ASAP was found. And 80 to 90% of the cancer that's secondary to ASAP, it is Gleason score 6. So we have very high percentage, that's of 80 to 90%, it is 6, Gleason 6 of this ASAP. The chance of developing cancer is more likely with ASAP than with multifocal high-grade BIN. The presence of ASAP does not seem to alert the BSA. So the BSA is not alerted by ASAP. The management of the ASAP is rebiopsy within 3 to 6 months because we have 40 to 60% of the patient with ASAP have a risk of prostate cancer in subsequent biopsy. And of this 60%, 80 to 90% is considered as Gleason 6. Increase of sampling from, so we will increase sampling from, we will do rebiopsy within 3 to 6 months with increased sampling from the atypical regions and also from adjustment regions. We'll come to speak about the diagnostic criteria for prostate cancer or prostate adenocarcinoma. Prostate adenocarcinoma originates from prostate epithelial cell, very important. So stain positive for prostatic specific phosphates, that's known as prostatic acid phosphates, BAP, and also PSA, that prostatic specific antigen. So the stain in prostatic adenocarcinoma is positive for prostatic acid phosphate, BAP, and also PSA. The normal prostate gland always have a basal cell layer, very important, as you see here. This is a sample from our prostatic tissue under the microscope show the basal layer. This is a basal layer. It is present in, and this is a laminar layer. So this is a basal, and this is a laminar layer. This is in the normal prostate. Again, this picture is very nice. This is prostate. We take a sample from prostate, and we see the outer here. This is the basement membrane, and the blue here, it is a basal layer or basal cell, and the inner we have luminal cell. Luminal cell. This is a luminal cell. Okay, and this is seminal vesicles. So here, this is the same. Very important to see the laminal cells, the basal cell, basement membrane, and stromal cell. This is the cell layer of the prostate. Okay, so it is 4. We have laminar, we have basal, we have basement membrane, and stromal cell. Okay, so the BSC markers, human, we have CD133 and AC130, CD44 integrin alpha 2 and B2. Mouse at CD133. This is for human, and this is for rat and mouse, just for explanation. Okay. So prostate adenocarcinoma never has a basal cell layer, so it lost differentiation due to hyper proliferation of the prostatic cell. So not even an incomplete layer. It is not present at all. Never. So basal cell stain positive for high molecular weight creatine. That's a HMWK. So it is positive, the basal cell stain positive for high molecular weight creatine. But it is negative for PSA and also BAP, that's the prostatic acid phosphate. Therefore, when it is difficult to determine if the cell are malignant, stained slide with HMWK because it is positive for a high molecular weight creatine. This is a basal cell stain. If glandular structure lack the basal cell, this is known as negative HMWK. So here cancer is present. If glandular structure lack the basal cell, so it is negative. But if it is positive, that means is not. That means there is no cancer because the basal layer is present. So basal layer positive, basal cell stain positive, that means you will find high molecular weight creatine. But if it's negative, that means it is cancer. This is a normal, and here this is the BIA, and this is a BIN. So as you see, this is BIA, small differentiation. Here, this is BIN. The basal cell layer is still available, but here we have destruction of the basal cell in the cancer, as you see here. Luminous cell hyperproliferation, loss of the basal epithelium, basement membrane breakdown, immune cell infiltrations, reactive stroma. This is molecular change, telomerase activation between the deletions and RB1 loss. But the BIN, luminous cell hyperproliferation, telomere shortening, and stroma cell reactivity. Okay, so this is the picture to show the basal cell as you see. This is in this picture here, this is a prostate. We have letter from A to D. This is sequence of section taken from the different position of the prostate in the top. This here in the top here left. This illustration produce offering combination and percentage of the focal tissue, a focal tumor tissue. But the letter of here from 1 to 3, this 1 to 3, this is will give average mutation signature between the foci here. And if you see here, this is considered as abnormal hyperproliferation of the prostatic cell and indicate malignancy. So the tumor thus model illustrates the difficult disseminating cellular diversity of the prostate cancer. We will speak about the type of the prostate cancer. We have adenocarcinoma arise from the prostate gland epithelial cell, acinar adenocarcinoma, that's more than 95%. This is the most common variant. Term prostate cancer generally refer to this entity. That's the acinar adenocarcinoma or adenocarcinoma of the prostate. It is more than 95% of prostate cancer. It's known as acinar adenocarcinoma. Prostatic ductal adenocarcinoma, a rare aggressive prostate cancer, rise from within the prostate duct. So this is known as prostatic ductal adenocarcinoma, therefore the name is duct. It assigned a Gleason score of 4+4 usually. Okay, so it is rare aggressive prostate cancer. It usually arises from the peripheral zone. Okay, this is a prostate cancer in general, arise from peripheral zone, but it tends to grow into the urethral lumens. Okay, so the ductal intraductal prostate ductal adenocarcinoma is usually from peripheral zone, but the prostate cancer commonly from peripheral zone, but can occur in transitional zone. Prostate ductal adenocarcinoma patient commonly have normal prostate on the digital rectal examination, present with obstructive voiding symptoms, and also patient might present with gross hematuria. PSA is often normal. So this is the prostatic ductal adenocarcinoma, and this is adenocarcinoma, acinar adenocarcinoma, which is more common type. This is aggressive one, prostate ductal adenocarcinoma, usually arises from the peripheral zone, but it tends to grow into the urethral lumen. Okay, so prostate ductal carcinoma can present with all this, but the PSA is often normal. It has a propensity to the metastasize to the lung, liver, testicles, and penis. This is prostate ductal carcinoma. It can be metastasized to the lung, liver, testicles, and the penis. Remember LLTB. LLTB, it's a metastatic site for ductal adenocarcinoma, which is aggressive prostate cancer. Ductal type is treated as the same as acinar adenocarcinoma. Acinar and ductal variant are often occur together. So the acinar and ductal usually occur together or often occur together. Genetic mutation, usually with ductal, appear to be more common in ductal carcinoma. So occasionally ductal adenocarcinoma may be misdiagnosed as high-grade BIN because they can have a similar appearance on the histology. So this is a ductal adenocarcinoma may be misdiagnosed as BIN because have a similar appearance on histology. Intraductal carcinoma, this is the third type of the prostate known as IDCB. This is arise from spread of the acinar adenocarcinoma into the prostatic duct. So spread of the acinar to the prostatic duct is known as intraductal adenocarcinoma. Therefore, its presence on the biopsy typically indicates as aggressive acinar adenocarcinoma. So the intraductal carcinoma is considered aggressive acinar adenocarcinoma. Okay, is presence somewhere else in the prostate. So if we find the patient have intraductal, the presence of the biopsy typically indicate that the aggressive acinar adenocarcinoma is present somewhere else in the prostate. Genetic mutation common with intraductal carcinoma of the prostate. It's common. Genetic mutation is common with intraductal carcinoma of the prostate, but also we have the genetic mutation appear to be more common with ductal carcinoma, and we have genetic mutation also appear to be more common with intraductal. Intraductal carcinoma misdiagnosed as high-grade BIN because they have a similar appearance on the histology. Non-adenocarcinoma, this is the second type. So we have adenocarcinoma, which might be acinar, ductal, intraductal. Acinar is the common 95%, and ductal, intraductal is considered more aggressive. When you find intraductal type, this indicates we have aggressive acinar adenocarcinoma. So we'll come to the less than 5% of non-adenocarcinoma. That includes transitional cell carcinoma, which is actually the most common non-adenocarcinoma. Non-adenocarcinoma is common. One, it is transitional. Transitional is the most common non-adenocarcinoma. Other cancer types includes small cell carcinoma and sarcoma. Location of prostate cancer. The most common location of the prostate cancer, the peripheral zone. As you see here, this is a bladder and this is a prostate. And as you see, we have this urethra and this is the ejaculatory duct. Here we will find the seminal vesicles, which is actually receive sperm and semen from the testicles. About 30% come from seminal vesicles with sperm from the testes as a source. And I would like to show you the zone, which is very important in this lecture. As you see here, this is anterior zone. This is pink color anterior zone, and the green color here is transitional zone. Transitional zone run anterior and posterior to the urethra, and the urethra, it comes through the transitional zone, okay, and also come through the peripheral zone. So this is the peripheral zone, which is most important for us in this lecture, okay. And here we have the central zone. So this is anterior, transitional, central, and we have the posterior, which is peripheral zone. So this is considered as prostate. And here the ductal, this is ejaculatory duct open into the prostate through the cribriform fossa. We have small colliculi that's open here, allow semen and sperm to come to this, and also include the secretion from the prostate itself. That includes seminal fluid, which is also about 70% compared with other come from seminal vesicles. So we come here to location of the prostate of the cancer, peripheral zone 70%, transitional zone 20%, central zone 5 to 10%, but rare we will find anterior fibromuscular, rare to find cancer in this. But peripheral 70%, transitional zone 20%, 10% is a central zone, 5 to 10%. Again, this picture to show you the different pathology of the prostates. There are focal atrophy. This might occur in the peripheral zone, as you see here, this color, in the fibromuscular zone here. And we have acute inflammation can occur in any zone, and chronic inflammation occur mainly in the peripheral zone. Okay, so occur mainly in the peripheral zone D zone here, peripheral zone D. Sorry, B here, that's anterior. And benign prostatic hyperplasia, this is usually occur in transitional zone, okay, which is actually this A here. Transitional zone, which is C here. This is central zone. This is anterior zone, or known as fibromuscular zone. A high-grade BIN can occur in the peripheral zone as a cancer, and carcinoma occur in the peripheral zone. This is a peripheral zone. So location again, as you see here, peripheral zone 70% for prostate cancer, transitional zone, central zone, and anterior fibromuscular. This is picture to show you the cancer can occur in different parts. Peripheral zone about 70%. Here this is peripheral zone, which is from posteriorly. And we have in the transitional zone, which is actually anterior and posterior to the urethra. This is a urethra, prostatic urethra. So all this is, and also can occur in central zone, which is 5 to 10%, as we see here. 5 to 10% in central zone. This is a typical demonstration. And as you see, this is a peripheral zone, and this is a transitional zone, which is 20%, and this is the anterior zone, anterior fibromuscular zone. This is a site for very important. This is site of benign prostatic hyperplasia. Okay, in the high grade benign prostatic hyperplasia, okay, transition zone. Sorry, I mean the site for focal atrophy. Focal atrophy can occur in the anterior zone. Focal atrophy, okay. Prostate cancer tend to be multifocal. As you see here, we have multifocality in this histopathology. This is nodules. It is multifocal, so it is appear in several areas of the histology. Also, as you see here, this is a multifocality in the histopathology. This is the prostates. As you see here, this is the right and this is the left. And here we have focal. This is the Gleason score of 4+3. And this is Gleason score of 5+4. More than 65% of the cancer are within 5 millimeters of the urethra. So this is more than 65% of the cancer are within 5 millimeters of the urethra. Okay, but 30 to 45% are within 1 millimeter of the urethra. Okay, so 65% of the cancer are within 5 millimeters of the urethra, but 35 to 45 are within 1 millimeter of the urethra. Thus, the ablative therapy that spare the periurethral tissue may leave cancer behind. The ablative therapy that spare the periurethral tissue may leave the cancer behind. Local cancer spread. Capsular penetration is most common in posterior and lateral prostate and near to the neurovascular bundle. This is capsular penetration. Most common in posterolateral prostate and also near to the neurovascular bundle. Capsular penetration is twice as common in the peripheral zone cancer and compared with transitional zone. So it is twice in the peripheral zone compared with transitional zone. Capsular penetration is more common in patients with high clinical stage, high-grade groups, Gleason score, that's high-grade group of our high lesions, and high preoperative PSA. This is a capsular penetration more common with this patient. Higher clinical stage, higher grades or higher lesions, and higher preoperative PSA. Higher lesions, that means high grades. So we have prevention of prostate cancer, smoking cessation. Smoking within 10 years of being diagnosed with prostate cancer appear to increase the risk of high-stage, high-grade metastasis, biochemical recurrence, and castration resistance and prostate cancer-specific mortality. So the mortality, all this is actually increase. So smoking within 10 years of being diagnosed with prostate cancer appear to increase the risk of high-grade, high-stage metastasis, biochemical markers, and also castration resistance and prostate cancer-specific mortality. Men with quit smoking more than 10 years. So if the patient quit smoking for more than 10 years before the diagnosis of prostate cancer have a similar prostate cancer-specific mortality as non-smoker. So smoking and non-smoking is no difference. So men who quit smoking for more than 10 years before the diagnosis of prostate cancer have a similar cancer-specific mortality as non-smoker. It is unclear if cessation reduces the risk of the developing prostate cancer. However, if the man quit smoking, he may reduce the risk of having aggressive feature if the prostate cancer does develop. Dietary supplement for prostate cancer preventions. List of dietary supplements include vitamin C, D, E, and multivitamin, selenium, and lycopene, and also soy. Omega-3 fatty acid appear to be ineffective for prevention of prostate cancer. So all this vitamin is very important. In men with high-grade BIN, oral green tea, that's catecheins, may decrease the risk of developing prostate cancer. Mediterranean diets may reduce the risk of developing aggressive prostate cancer. Vitamin E, multiple randomized trial, including we have SELECT and HOPE and also BHS2, show that oral supplement with vitamin E does not reduce the risk of the prostate cancer after 7 to 10 years of follow-up. So it is actually selected trial randomized on 35,533 men or age of more than or equal to 50 with PSA less than 4 and normal prostate exam in 4 groups: placebo, vitamin E, that's tocopherol, that's 400 per oral per day, selenium L, that's selenium methitoins, 200 milligram per oral per days, or both vitamin E and selenium. They use this. After the median follow-up over 8 years, none of the intervention reduced the incidence of the prostate cancer, but vitamin E significantly increased the risk of the prostate cancer. HOPE trial randomized, that's 9,641 men with age of 55 to placebo or vitamin E. That's tocopherols 400 per oral QDs. After median follow-up for 7 years, vitamin E did not reduce the incidence of the prostate cancer. So in the first study, we show that the vitamin E increased the risk of the cancer, and in this study, it doesn't actually reduce the incidence of the prostate cancer. A physician health study 2, that's FBHS2, randomized trial on 14,641 men age more than or equal 50 to placebo, vitamin E, tocopherol, that's 400 international unit per QDs, vitamin C, 500, or both vitamin C and E. That's after median follow-up of 8 years. None of the intervention reduced the incidence of the prostate cancer. Vitamin C several studies, including Proteus and BHS, showed that the oral supplementations with vitamin C does not reduce the risk of the prostate cancer after long-term follow-up. Vitamin D, the VITAL study showed that the oral supplementation with vitamin D does not reduce the risk of the prostate cancer after 5 years of follow-up. A higher serum vitamin D level does not reduce the risk of the developing prostate cancer nor the risk of dying from prostate cancer. Multivitamin component of the BHS2 randomized 14,641 men age more than or equal 50 to placebo or an oral daily multivitamin after median follow-up 11.2 years, the multivitamin does not reduce the incidence of prostate cancers. Selenium multiple randomized trial, including SELECT and MPT, show that the supplementation with selenium does not reduce the risk of prostate cancer after 2 to 10 years of follow-up. Soy protein. A few small randomized studies suggest that the oral soy protein does not reduce the risk of the prostate cancer after 2 to 3 years of the follow-up. Omega-3 fatty acids and the VITAL study show that the oral omega-3 acid does not reduce the risk of prostate cancer after 5 years of follow-up. Lycopene, randomized trial and non-randomized trial suggest that the lycopene may decrease the PSA but does not prevent prostate cancer. Green tea catechin, that limit data suggests that the oral intake of green tea catechin in the male with high-grade BIN may decrease the development of the prostate cancer within 1 to 2 years of follow-up. Mediterranean diet limited retrospective studies that suggest that the men are less likely to develop an aggressive prostate cancer when they have diet rich in fruits, vegetable, fish, and legumes and olive oils. So the medication for prostate cancer prevention. Metformin only non-randomized control study have done. The quality of data is poor and the data are conflicting as whether the metformin can prevent prostate cancer. This is as antidiabetics. They mentioned that the data is poor and the data are conflicting. Statin retrospective data indicate that the statin do not reduce the risk of developing prostate cancer. 5-alpha reductase inhibitors, it is actually according to 2 trials, as a BCBT trial, prostate cancer prevention trial, over 18,000 men aged more than 55 with normal prostate exam PSA less than 3 or equals 3 were randomized to 7-year course of placebo or finasteride 5 mg per oral daily. The study also reduced by dutastrides of prostate cancer events. That's over 8,000 men aged more than 50 with negative prostate biopsy, prostate volume 80 cc, and PSA 2.5 to 10 were randomized to 4 years course of placebo or dutastrides 0.5 mg per oral daily. In these studies, 5-alpha reductase inhibitors reduce the risk of the relative risk of developing prostate cancer by nearly 25%. So it's very important. And also, even in the patients actually belong for surgery, the 5-alpha reductase inhibitor is helpful in minimizing bleeding. So it can be used 3 to 1 month before the surgery. It's very helpful. 3 weeks to 1 month to 3 weeks, or 3 weeks to 1 month in reduced bleeding intraoperatively. So it also considers decreasing the cancer by 25%. However, a subgroup analysis showing that the 5-alpha reductase reduce the risk of developing cancer with Gleason score less than 6, but slightly increase the risk of developing cancer with Gleason score of 8 to 10. So it can increase the risk of developing cancer with Gleason score of 8 to 10, despite a slight increase in the risk of the Gleason 8 to 10 cancer. Long-term follow-up 13 to 15 years show that the equivalent overall and prostate cancer-specific survival in men with prostate cancer, whether they took 5-alpha reductase or placebo. Approximately 75% of the prevented cancer are very low risk and also perhaps clinically insignificant. The absolute risk of developing a Gleason score of 8 to 10 cancer is increased by less than 1% in men taking 5-alpha reductase inhibitor. So putting the data into the perspective, out of 200 men receiving 5-alpha reductase, one man will be more likely to develop Gleason of 8 to 10 cancer. 3 men will be less likely to develop a potentially clinical meaningful Gleason score of less than or equal 6 cancer, and also approximately 8 men will be less likely to develop very low risk and potential clinical insignificance, so lesion score less than or equal 6 cancer. The greater risk of developing high-grade cancer while taking 5-alpha reductase does not increase mortality. Conversely, the greater chance of preventing low-grade cancer while taking 5-alpha reductase does not reduce the mortality. Taking 5-alpha reductase increases the risk of erectile dysfunction and low libido. The FDA did not approve 5-alpha reductase for prevention of prostate cancer. Thank you. This is the end of the lecture. We will meet again in another one.